This is a case of preoperative embolization for a large posterior fossa meningioma. Patient's a 46-year-old with chronic headaches with dysmetria and intention tremor on exam. MRI shows a hypervascular large posterior fossa tumor causing mass effect and cerebellar edema. It appears to be originating off the sigmoid sinus on the right side. An angiogram is performed to evaluate patency of the sinus as well as for consideration of embolization. Right vertebral artery access is being obtained. Typically, this is the hardest vessel to catheterize. A 6 French guide is advanced over and introduce a catheter. A roadmap is created. Access is obtained with the new 035 wire into the right vertebral artery, and over that the 6 French guide is advanced till it's stable in the mid-cervical vertebral. An injection angiogram reveals the large hypertrophied posterior meningeal vessel which is supplying the tumor, as noted here. Again, you can see this is an extracranially located vessel distinct from the posterior inferior cerebellar artery. Angiogram clearly shows where the vessel is located. The microcatheter is now attempted to be introduced, and because of the angles, it is difficult to get access into this vertebral artery. You can see the farther distal origin of the pica. There, the wire is introduced into the proximal vessel. It should be noted the microcatheter here is a marathon over an 010 wire system. You can see using microcatheter and wire combination, we are able to advance the microcatheter at least through the ostia of this vessel. There, an injection reveals that we are indeed in the appropriate vessel. Therefore, wire is brought back in, and we try to get farther distal along this vessel. There you can see the wire is being advanced, as is the microcatheter, trying to deliver it as distally as possible, which reduces the risk of reflux into the vertebral artery and also spares inadvertent ischemia of non-affected tissues. There we believe we are distinctly into the primary tumor supply with excellent blush noted of this large meningioma. We prepare the microcatheter with DMSO as is standard, and then inject onyx. You can see the onyx that will start to show up through the microcatheter. In both AP and lateral planes. There the onyx is coming out, and you can see it's adopting the same configuration as previously noted angiographic supply. There's always some reflux, but we make sure that we limit it to a maximal extent. After occlusion of the supply of the tumor, the microcatheter is removed. An angiogram reveals obliteration of the hypervascularity that was previously noted. Final angiogram reveals patency of all the branches and obliteration of the vascularity. This is a post-op MRI showing complete resection of the tumor.